All right. Well, good afternoon. Thanks for joining us. If you have questions throughout the webinar, please put them in the Q&A box, and we are recording this, so you'll be able to watch it again or share it with anyone that you'd like. We're so glad that you're here to learn about how the Institute for Clinical and Economic Review values drugs for people with cystic fibrosis and other rare diseases. They do this based on the Quality Adjusted Life Years Formula, or QALY, and it threatens all of us because they have the ear of the insurance companies. They're a self-appointed group, and they are not looking out for our best interests. I'm Laura Bonnell, the Executive Director of the Bonnell Foundation, and we help families, CF families in Michigan and across the country with financial assistance, college scholarship, and lung transplant grants. And these are my college-age daughters, Molly and Emily. I also do a lot of advocacy. We are actually in the midst of getting the Rare Disease Advisory Council in Michigan up and running. So right now we're going to start talking about ICER. I want to introduce our two panelists. Sarah Van Geertruden is the Executive Director of the Partnership for Patient Care. And she's a wealth of information and among the best advocates that we have. And she's going to start us off, but I'm also want to let you know Beth Van Stone, who you see is the director of the Cystic Fibrosis Advocacy Team, CF Get Loud. She is the mother of two daughters, the youngest who lives with cystic fibrosis. She lives in Canada and will bring us so much insight on how things work or do not work for people with CF there. So Sarah, it's all yours.
Thank you. Well, thank you so much. I appreciate everything that you guys do. Laura, we've known each other for so long now, and I really appreciate the leadership that the cystic fibrosis community has brought to these issues. I'm just going to start off with a little bit of information about the Partnership to Improve Patient Care. Our chairman, Tony Coelho, is a person with a disability. He has epilepsy. And was the original author of the Americans with Disabilities Act. So when the Partnership to Improve Patient Care was created, he really came to this with a personal experience and background, and I think genuinely understood the challenges that patients and people with disabilities face, particularly in the context of access to care, but also in the context of research. So when PIPSI was created, it was actually back in around 2008, 2009, when comparative effectiveness research was a really hot topic here in the United States. Congress was debating whether or not to create an institute that would do more comparative effectiveness research. And what we were consistently hearing from the patient and disability communities was that they wanted to be at the table in determining what kind of research an entity like this would be doing. They wanted to be on the board of governors. They wanted to make sure that that the research was answering questions that they cared about when they actually went to go make healthcare decisions. And so we're really excited that as a result of this coalition coming together and a lot of its advocacy, the Patient-Centered Outcomes Research Institute was created, which is, it was created as part of the Affordable Care Act. So it was created by Congress, but it is an independent entity. Since PCORI was created, we've also gotten very much engaged in sort of trying to make sure that all policies meet some sort of patient-centeredness criteria where we're really measuring their success based on outcomes that matter to patients. And we talk a lot too about now development of criteria around value frameworks that are patient-centered. This really has come up in response to the development of value frameworks that haven't been so patient-centered, that create cost-effectiveness standards for what will or will not get covered in a way that potentially harms patients and people with disabilities. So that's where we get into this issue called the Quality Adjusted Life Year. The metric that Laura just mentioned is a measure of disease or disability burden and treatment efficacy in mitigating it. So when you think about the QALY metric, a 1 is perfect health, a 0 is death, and most of us probably fall somewhere in between. But particularly people with disabilities or people who live with chronic conditions will fall lower on that scale between 1 and 0. So this is a good chart that I like to use to sort of to describe the QALY and the health utilities. So when you put a health utility in, what is the value of a person's life in a year living with a certain disease or condition, this is where those different ones fall. I like to point out all the way to the left, ALS, which is actually a negative 0.05. And what that indicates is that on the QALY scale, living with this particular condition is considered a state worse than death. So when you think about the QALY, there are some conditions that will actually fall below the 0, which is quite frightening, because then you think to treat this condition would potentially be considered a very low value, particularly if you're not curing, you're just maybe mitigating some side effects but it's not a cure. It's not going to get this person all the way up to the 1. And that's where, so you might bring someone with spinal muscular atrophy from a 0.2 to a 0.3. For the person who's living with that disability, that might be tremendous in terms of the value that it presents to them in their daily lives, but wouldn't necessarily look to be particularly valuable when the QALY is used to measure the value of a treatment that gets you from that 0.2 to a 0.3. So the challenges that we have with this metric is that using this QALY, extending disabled life is worth less than non-disabled life. If you're a 0.2, that doesn't look as good as somebody who is going to get closer to a 1. The process of translating clinical outcomes into utility scores also results in a loss of information. So a lot of times what we'll see with these value assessments is that they'll look at conditions in the context of mild, moderate, severe, for instance. Well, a lot gets lost in the nuances of mild, moderate, severe. You don't often ask somebody how they feel, and they say, I feel moderate today, So a lot gets lost in the translation when you use this kind of metric. People with disabilities also may attach different values to their health states than the general public. And this really gets to the concern that those health utilities that you just saw are derived from surveys that are done to the general population. These are not surveys of patients themselves. These are surveys of the general population saying, what would you think if you lived a life with this condition, and this is what your life was like with that condition? And they'll describe that condition to a person, and the person would say, some of you may be familiar, there was a study that was quite scary a few years ago in the New England Journal of Medicine, I believe it was, or JAMA, where they talked about states worse than death. And some people would say, for instance, I would rather be dead than blind. Well, if you ask a person who actually is blind, they probably would disagree with you, because as long as you're well accommodated with your condition, you actually would perceive your life to have tremendous quality and to be living a life, living a high quality of life, assuming that you have treatments and accommodations. So it gets very confusing when you're asking people who don't understand what that lived condition is like. And then
I think one point, Sarah, I think too, is also what happened with Trikafta, is that the QALY based on ICER told the insurance companies that it was not worth paying for this drug, even though it changed the underlying condition for people who had this disease. It was making it from fatal to a chronic illness. Based on that criteria you're talking about, then it was their recommendation that it was too costly and not worth it.
Exactly. Well, and I think in Canada, the cost thresholds are much different. Is that right?
That's correct. I believe the QALY is 50,000 is the maximum. So if you're looking at a drug like Trikafta that actually corrects the defective gene in your body, and it's so that people will actually test negative for that disease as long as they continue on that drug, and the top they're willing to pay is 50,000, that's just not going to happen in most cases. So that you're knocked right off the opportunity for the drug then. So
that's a very low number.
Yeah, ridiculous.
Mm-hmm. Well, and last but not least, when you look at the QALY, I think part of the challenge too is that when these QALY-based assessments are being done, it's typically being done on the basis of randomized clinical trials. And here, at least here in the United States, when groups are doing these value assessments on drugs in particular, they're being done right at the time when the drugs are being approved. At that moment, there is not a lot of real world evidence because the drug hasn't been out on the market yet. And so it takes a long time for what clinicians see and understand in their patients and how their patients are reacting to particular treatments to then get translated back into the research. So I think one of the other real challenges with the QALY is that this clinical knowledge that providers have doesn't necessarily get translated into the research literature and therefore isn't being translated into the value assessment. So here in the United States, we have a long history of opposing the quality adjusted life year. And I'm excited to hear Beth talk a little bit about what her experience in Canada, because in other countries, the QALY has been more of a metric that's been relied upon by policymakers. But here in 2010, when the Affordable Care Act passed, and I talked a little bit earlier about PCORI, within PCORI's statute was not only a bar on the use of the QALY by PCORI as they compare different treatments, but there was also a provision in that law that prevents our Medicare program from using the QALY as the basis for coverage reimbursement and incentive programs. And going even further back, Section 504 of the Rehab Act ensured that individuals with disabilities would not be excluded from participation in, denied benefits of, or otherwise subjected to discrimination. And that was extended by the Americans with Disabilities Act to state and local governments, making that law also applicable then to Medicaid programs. Under the Americans with Disabilities Act, that was passed in 1990. In 1992, the administration under the first President Bush established that Oregon's efforts to use a cost effectiveness standard in Medicaid would violate the Americans with Disabilities Act. And they explicitly talked about the quality adjusted life year and their concerns that if Oregon were to move that waiver forward as is, that there would be discriminatory implications in terms of what they would or would not cover. So we also have that precedent here in the United States. That being said, the issue continues to come up. I think there's been a constant fight around this potential use of QALYs. And so in 2019, the National Council on Disability, which is an independent federal agency that was established to advise Congress and the administration on disability issues, they came out with a report where they provided a series of recommendations. But the nutshell of it is that they recommended to policymakers that they not base policy decisions on the quality adjusted life year. And they even went so far as to say, we don't think the United States should reference prices in other countries or policies in other countries because they are often in reliance on the quality adjusted life year.
And just in case anyone has any questions, just a reminder, you can put them in the Q&A. If for some reason you cannot send questions in the Q&A, you can text them to 248-520-2329, 248-520-2329, or put them in the Q&A. Thank you.
We may have questions. Some of this information may get complicated, so I'm happy to do that at the end. So the other thing I would just note in the United States is that there has long been a bipartisan, this opposition to QALYs from a policy level, it has been very much bipartisan, which I think is a great relief. So we have not only the National Council on Disabilities work against the use of QALYs, and they are very much nonpartisan. Just recently in the last campaign cycle, the DNC platform made an explicit statement against the use of QALYs. Democrats have put QALY bans in various bills. We've got some statements by now President Biden against the use of QALYs when he was a candidate. Senator Warren made the comment that QALYs are an example of historical discrimination in a letter that she did with other senators over to the HHS Office for Civil Rights when they were advocating against discrimination in terms of COVID-19 care. And then we also have just going back to 1992, that was a Republican administration that took that action against implementing a QALY-based benefit design for Medicaid back in 1992. So why do we all care about this issue so much? So recently, the issue of QALYs, despite this long history, it has reared its ugly head sort of here in the United States because of an entity called the Institute for Clinical and Economic Review. We call it ICER, ICER. ICER is a private research organization that conducts research looking at the price of healthcare interventions, and it's they're doing this as a cost effectiveness assessment, and then those cost effectiveness assessments drive payer decisions around what they will or will not cover, where they put it on their tier, what their cost sharing is, et cetera. And so our concern about ICER is that A, they rely on the quality adjusted life year. B, they fail to meaningfully engage expert stakeholders. And so I know there's often concern that the voting board that looks at cost effectiveness won't necessarily include a physician that treats patients with those conditions and doesn't include patients with those conditions or their loved ones. It fails to consider outcomes that matter to patients and people with disabilities. So there are examples historically where ICER may have failed to include things like caregiving costs, or to consider that the value of decreasing fatigue, the value of increased mobility and ability to go to work, things that are extraordinarily valuable to the individual patient, but not necessarily valuable from a payer perspective. Also, their assessments tend to be premature because they're done right at that moment when a treatment is being approved. And so there's not a lot of real world evidence yet. And there's a lack of transparency to people who are living with those study conditions as to how they come up with those conclusions. So we often hear from others who try to replicate an ICER decision or try to understand what their methods were for getting to that conclusion. It's very difficult to do that because it's not like an open source peer reviewed process. So the implications for vulnerable populations are significant. Quality-based models are largely rely on randomized clinical trials. We all know that those randomized clinical trials tend to lack minority participants. So they're not capturing data from people who aren't necessarily, white, male, non-Hispanic populations. So, and then quality-based models also omit attention to the evidence that differential triggers like pollution and food insecurity has on the expression of disease and illness. And so we're all aware of this, like social determinants of health is a really hot topic here. Those kinds of issues are not really accounted for in a quality-based value assessment. So the current environment here has been dicey on these issues the last few years. We've seen since ICER has gotten tremendous funding to do this kind of work. In 2018, we saw CVS look to do a quality-based benchmark where they essentially said, we're not going to cover certain drugs that are more than $100,000 per QALY. They were going to offer that to their employer clients. There was intervention from patient groups to say, hey, that's not fair. That doesn't make sense. They stopped marketing it, thankfully. But we are seeing ICER now in multiple states kind of selling their value assessments to states as a means for them to restrict coverage in their programs, particularly in Medicaid. So policymakers, and these are buzzwords that I often encourage advocates to think about when you're looking at state legislation, always look for the buzzword cost effectiveness or value, because those all sound really good, right? We all want what's cost effective and valuable. The question is, how do you get to that conclusion? And too often the terms cost effectiveness and value are code words for using quality adjusted life years to come up with those numbers. The other way that that you have to be very careful is about what we call reference pricing. There are a lot of proposals out there to reference the prices of someone else, particularly Canada and the States. That's been a really live debate here in the United States, and various states, state legislatures have been looking to reference Canadian prices, which Beth will talk more about, but also rely on the quality adjusted life year. And so it matters to us here in the United States because it would, if we were to move to a system where we relied on a quality-based value assessment to determine what we would or would not cover in Medicaid, this is a study that shows what the implications would be for certain types of patients. 42 to 99% of patients across 5 disease areas would be required to switch treatments. All Medicaid patients with MS would be forced to switch treatments. 87% of rheumatoid arthritis prescriptions would change. And the same thing would happen in Medicare Part B, where certain drugs are also covered. 55 to 62% of patients across 4 disease areas would be required to switch treatments, most impacting MS patients. And so we often hear that other countries do better than we do in terms of coverage. That might be true for healthy individuals, but I think the concern that we find in the patient and disability community is that people who have really high cost needs, expensive conditions that they're living with, are not getting better treatment in other countries. If you look in terms of cancers for breast, colon, lung, and prostate cancers, the 5-year survival rates are higher in the US than in Canada, France, Germany, Italy, Japan, UK. Fewer options, 80% of cancer meds reviewed by the United Kingdom health officials between 2007 and 2014 had some form of access restriction. And we have a slower, more delayed access to treatment in other countries than we do here. And I know that we'll hear a lot about this from the cystic fibrosis perspective. And actually, Laura, you've gone through some of this in terms of what access I think your daughter has had to certain treatments as well, right? Not just in the context of drugs too.
Correct. I mean, just last week, the insurance company contacted us or her and said they weren't going to cover a CT scan because they didn't believe it was medically necessary, regardless of the fact that the doctor said it was medically necessary. So they said they weren't going to cover the cost. And then they also canceled her CT scan that was scheduled for her 6 weeks after the last one. So we're working on that. But yes, it's constant, as Beth knows, and it just doesn't stop.
No, and Canada, when we're looking at the experience in other countries, currently, just with respect to the drug Trikafta, which is the big golden goose right now in the cystic fibrosis community, Canada is literally still awaiting approval of that drug, while patients in the US have had access to it for, I think, a year and a half. In the US, that drug was fast-tracked and was put through the FDA approval and was to patients in 90 days. We had the drug submitted through priority access, which puts 2 of our regulatory bodies working together to try, like Health Canada and CADIS, which is a health technology assessment. I think it's maybe something like ICER. It recognizes or tries to recognize the efficacy of the drug and the value, etc. It has those 2 working together. That was high priority review, was 180 days. So we're still waiting for the Health Canada approval. And once that's done, we have another step, which is the negotiation, which is the Pan-Canadian Pricing Alliance piece. So after all of this, trying to get it approved, recognized for reimbursement, and then a negotiation process. And then from there, each province, like your states, each province then has to decide whether or not they will add it to their formularies to pay for the coverage for this drug. So we are so far behind, and things are getting worse. Trikafta had a big delay because of some new pricing regulations that have been changed that are putting expectations on drug companies of dropping prices 98 to 99% from the market value. Those are the discounts that they're expecting from pharma, which is cooling off anything that's coming into Canada. We have a very small portion of the market. I think we're like 2 or 3% of the world market for pharmaceuticals. So having those drastic cuts or expectations to get prices down, we're not even going to have that. Even if you're a multimillionaire and could afford to fund it, we're not going to have access because they're not even going to be submitted here. So it's a pretty chilly environment in Canada right now for rare disease drugs.
Well, that is I mean, that's incredibly sad because that has a real impact on real people. When you have to wait so long just to get access.
And like you said, they are literally dying in Canada while they're waiting for this. And, you know, here in the US, it was just approved for children 6 to 11 years old with specific mutations. The FDA just approved that yesterday. So.
And it is absolutely heartbreaking because our community is very close. We have friends with CF all around the world, and I know our community is so tight. So we look to our friends in the South, and we are thrilled to see them having access and see them pulling the IVs out of their arms and getting back to work. There's a thing called the Trikafta babies now because they're all having babies. And we celebrate with them, but at the same time, as we watch our patients losing the fight here, it's heartbreaking. And you try and put it into, like, why with that little bit of a boundary, why do we not have access? And the US does. So things have to be done better, and patients have to be put at the middle of getting these drugs. That has to be the focus.
Absolutely.
Well, and you know, and this slide gets a little bit more to this issue as well. Yeah, that's a really interesting description of how Canada works. And yeah, and we were very impressed when the National Council on Disability really dug into this. Their 2019 report pulled out lots of examples from various countries as to where access restrictions were being used, and particularly where they were being used and based on quality adjusted life years. And so we know that these metrics are being used in other countries, not just in Canada. But yet we are in this country often looking to use other countries as a reference point for our health systems, which I think is part of what has really made this a scary proposition. And I always like to pull this reference to what the National Council on Disability said in their report, that the resulting rationing is an existential threat to people with disabilities. And so this is just a little chart that we actually have on our, I can send out the link or put it in the chat room when I'm done, but it's a link to a map that we pulled together to look specifically at different countries. And it's an interactive map that you can get to on www.valueourhealth.org. But it's kind of fun to play with, but scary too, because it provides a lot of information around what the QALYs are in the various countries, and then what the implications are for what they cover and who can get access. And so when I talked about the policies here, we saw this proposed policy to reference other countries when President Trump proposed it as what's called an international pricing index in 2018. That was, of course, recommended by the National Council on Disability to be rescinded, and disability advocates were obviously very opposed to it. The concept, though, was then later introduced in the House of Representatives here in 2019 and has been reintroduced now in the House. It's had hearings, but hasn't moved again as a bill in this particular Congress. And then also, after the International Pricing Index proposal, President Trump came out with something that was even more egregious, called Most Favored Nation. And that particular rulemaking would have just referenced the lowest foreign price to incorporate into Medicare Part B. That also generated opposition from the National Council on Disability. But as I mentioned earlier, states are looking at this model as well. So when I talked about the states, you know, I think with tight budgets there, you know, and I think we're all aware of the strain that states are experiencing because of COVID-19 and everything else that's been going on. Unfortunately, a lot of states are really looking to advance the use of QALYs as a means to cut costs. In New York, actually, even long before COVID-19 hit, they were referencing quality-based value assessments, which has an impact on how they value cystic fibrosis and SMA treatments. That was sort of the first state that we saw this issue rear its ugly head in. And But then we see states like Massachusetts trying to replicate New York. They have a health policy commission there that now is authorized to look at drug values. They have actually gone into an explicit contract with the Institute for Clinical and Economic Review to come up with their value framework, which has been concerning to advocates who oppose the use of the quality adjusted life year. In Oregon, we see them also considering what they call a drug affordability board that would be similar to what New York and Massachusetts are doing and using quality-based value assessments to come up with a value and then to essentially create what's called an upper payment limit for drugs based on that information. Colorado is, I think, about to pass a bill that would essentially do that. We know that New Jersey is considering a similar bill. We've seen these issues come up in lots of states. The three buckets of bills that we sort of tracked across the country this year were the one to explicitly reference Canadian prices. That was a big one that came up in Oklahoma, Minnesota, and a few other states. There was another one that would rely on ICER. ICER does a separate report called around unsupported price increases, where they have sort of designated themselves to decide what price increases are appropriate. The bill that was being contemplated in some states actually would have codified ICER as an entity in their statute to reference their report. It did not end up passing in any states that I'm aware of at this point. And I think there were a lot of legal concerns with codifying them in statute too. And then their drug pricing review board, as I mentioned before, would essentially allow a state to reference a third party to do a value assessment that then would trickle into how states provide access to those drugs and reimburse those drugs by state. So that's obviously of great concern. And that's the one that we actually see moving in more states, that these drug pricing review boards. And they don't explicitly say QALY in them, which has, I think, been a real challenge in terms of advocacy, because advocates, the sponsors of these bills will say, well, we don't talk about QALYs, we don't use QALYs, but because they provide the authority to reference a third party, that what we're seeing in other states that have these boards is that they end up referencing ICER or ICER studies, which are quality based. So it's something that we have to, it has to be explained, and once it's explained, then people understand it. But it's presented a real challenge for advocates. So we have developed some legislation in partnership with a lot of other organizations that support principles for patient-centered value assessment. When we all got together and said, well, what can we be for? What would we want states to do? And so we came up with a template bill, a piece of legislation that would essentially create patient protections so that if a state were to move forward legislation like what we saw before, it would essentially preclude that legislation from being able to discriminate. So it would create standards for patient-centeredness in research and analysis, making sure that it's things like peer-reviewed, which sounds simple, requiring engagement of patients and people with disabilities, and making sure that it's transparent what kind of evidence is being used to support the decisions that are being made in states. I think we all know that a lot of times these coverage decisions, people don't understand how the payer got there, right? What was the evidence that they were using to make that decision? It's not always transparent to the consumer. And so this legislation would do that in states. It has a prohibition on reliance on discriminatory measures, which is essentially what we call a QALY ban. And then an appeals and physician override mechanism. So, we've been really excited to have that as in this potential legislation as well. Most of a bill kind of like this, or based somewhat on this, actually did pass in Oklahoma. So we do have a precedent for one state at least taking this up. We've got some legislation that's been introduced in Massachusetts as well that we're hopeful might move and mitigate some of the damage from potential quality-based value assessments being used by their health policy commission. That's been, I think, a really nice step forward. And I wonder too, Beth, and what would this look like in Canada? And What do you have an opportunity there to advance patient protections like this?
So, well, right now our biggest fight is the PMPRB that I was discussing, because that block and having somebody actually put a border up around incoming medications and innovative medicines and treatments is putting us further behind than we already are. We're already so far behind, and this cold war that our government has going on with pharma is just making it worse. CADIF, which is like our ICER, once again, it's the same situation. We have bureaucrats there making decisions about patients' lives that don't understand the disease, that don't understand how some of these drugs can work. They don't understand outcomes. Sometimes a positive outcome means that you're not dying from your disease because it's been halted. So, for example, cystic fibrosis, you may get the drug and your lung function is at 70%, so someone may get that drug and have an increase to 90, and like, that's fabulous. And that's a big win. Somebody else might just stay at 70 and not decline to 40. And that's a big win as well. Why is that not being considered? People that don't understand the diseases, because there's many, are not making these decisions. We have specialized clinics for a lot of these diseases, very top-notch doctors and clinics that are caring for these people. They have very little input into these decisions. I think they should be weighted, their opinion should be weighted a lot more heavily. They treat these patients day in and day out. They understand these diseases, and a lot of them are very, very complicated, and their voices need to be heard when these decisions are being made. I think they are okay to write a prescription for an antibiotic and stop it if it's not working. Why are they not given that same empowerment to write a prescription for a gene modulator and then determine if it's not being effective themselves? They're not being trusted with the prescription pad, right? So that to me is just really frustrating. And we need to have people in there that are more patient focused, that understand these diseases a lot better than they do, and that can actually recognize outcomes and what a successful outcome is, like you were saying, because a successful outcome is not dying. Like, how's that for a successful outcome, right? And that seems to be left out of the equation.
I was going to say, Beth, when you were talking about that, one thing that we found also was that these ICER panelists or doctors these are general internists. They have no relationship to cystic fibrosis. There are no experts in these diseases on these panels. So they're not even capable of making a correct decision based on their lack of expertise.
They don't understand the disease. Half the time they don't understand how the actual innovative medicines work, right? So how can they be determining who gets what, and if they can stay on it, and how much it's worth? I don't think their opinion really should weigh as heavily as it does in these decisions. Patients need to be looked at. It was a perfect example, the QALY about the blind person. So a person that's dying of CF and has 60% lung function, and all of a sudden the disease is halted by a gene modulator, they're like, yes, I can go on for another 20 years, 25 years with 60% lung function. I can work, I can raise my family, I can do all the things. Why does that not matter? Why does it have to be an increase of 10%, 15%? Who makes that determination? Why is it not the patient? Why is it not the caregiver? Why is it not the family? That's somebody's father, somebody's husband, all these people are left out, and the people that are making the decisions are the people that don't have a clue what it's like. And to me, it's just so frustrating to have, so little of input from people that really know and can make those educated decisions on people. People's lives are at stake.
Right. And we saw this obviously during the pandemic, where we heard from people who said that they were told, specifically in New York, that because they had cystic fibrosis, they weren't going to get on a vent should they need one, because it was going to people whose outcome looked better.
Yep.
So.
But here they were not sick enough to be moved up the list to get a quicker access to the drug, but they were too sick to be put on a ventilator should they catch that disease.
Right.
Figure that out, right? Like that was just a double slap, and I was fighting, tooth and nail to have CF patients. It's a respiratory disease. Like, come on, move them up the list to get these drugs. Canada had like, we're so far behind you guys in trying to access these modulators. And it's a lot in part due to the very cold war that they have with pharma. We were way behind everybody, but to be that far behind and have CF patients without any coverage, and then knowing very well that they're the ones that are going to go in and say, well, you know what, you're just too sick to be put on that ventilator, so sorry for you. Oh, you couldn't get access because you weren't sick enough. It was ridiculous. I get so frustrated with our system.
Well, and I think that, but what you're saying is is meaningful in the COVID-19. Here we were having a fight with states on crisis standards of care, where states were actually explicitly stating in their crisis standards of care that when there was a shortage of ventilators, these are the people that will come in line first and last, and people with disabilities were being put last based on the use of other types of discriminatory metrics, looking at how many life years they had left after treatment. And that has been a huge fight, but I think has also really raised awareness of how discriminatory metrics get used in policy and what that impact then is for, it's discrimination, right? I mean, we in this country have civil rights laws that prevent discrimination, and yet we still see these discriminatory metrics making their way into policy. And that's been a real problem. And it's been a fight that a lot of disability rights lawyers across the country have been highly engaged in throughout this COVID pandemic.
And how, Sarah, do you think it's going? How much of our public is educated on this subject about ICER and the QALY? Do you think we still have so far to go?
Yeah, we have a long way to go. And it is in large part, it's inside the Beltway. I would argue that here, when I say inside the Beltway, I mean, the Washington, D.C. area. These issues have been a hot topic because there is a lot of debate about lowering drug costs and the potential for using QALYs to do that. And so there has been an opportunity to do a lot of education here. And I think that we've made some headway. That being said, when you get outside of this little bubble that we all live in terms of federal policy, right? And we learned this over the last year with these, I described these 3 different bills that have been percolating in the states. These bills were being promoted by a group called the National Association of State Health Policy. Legislators probably didn't know a lot about these bills, but were pushing them because they seemed like a good idea. And what we were finding in these various states is that a lot of times the advocates there had no idea what a QALY was. They had no idea that Canada was using QALYs. They had no idea that when the Drug Pricing Review Board legislation says we're going to reference a third party, what that meant, and what that potentially meant in terms of how policies in that state might translate then into limited coverage, where states are looking to try to cover fewer drugs in a class. They're looking to move drugs among tiers to increase copays and use utilization management strategies like step therapy. And they use these quality-based studies to justify those decisions. And so, but until advocates understand it, it's difficult to engage and to help legislators understand it. So yeah, the state-based stuff has been tough, which is why I'm really appreciative you're doing this webinar, because if advocates in states don't understand this, then they won't know what to look for when these bills come up.
Exactly. And what would you tell the people who are watching? What action should they take? What do they need to do to get the word out, to make sure all their legislators and all the people in their either rare disease community or cystic fibrosis know about this?
So I would argue we need to be doing more of this, just helping people under like the kind of the QALY 101. You start there. What is a QALY? Understand it, know what it is. But then, I would say this template legislation that has been developed by patients and people with disabilities, it's important to, even if your state's not using QALYs at this point, or if you're not aware of how they're using them, passing this kind of legislation is a great way to mitigate those kinds of bills going forward, right? So if a state passes a board bill where they're creating one of these drug affordability boards, everybody wants affordability. Let's just make sure that you also have the QALY ban in your statute to prevent that board from using a quality-based reference point to do so, right? And so I think, so to me, I would advocate that, states need to be thinking about this template legislation and advocate to the extent that advocates can get that over the finish line. I think it'll help a lot to mitigate other legislation that might be considered.
I was going to say, education is key. And I've noticed in the last 20 years that I've been advocating, the level of education with our advocates has leveled up huge, because we educate our advocates then go and have to educate our members of parliament, because they don't understand. They don't know, they're just going with the flow. They have a million things on their desk. They don't understand each and every one of these policies and how it affects patients. So by just educating the advocates, and they've educated themselves amazingly, and then going to the members of parliament and then having them raise it in the House, it's made a huge difference, and people have got loud. And cystic fibrosis in particular as a very small group, has made a lot of noise about some of the changes that we're not okay with, right? And so I think it all starts with education and getting everyone to understand ICER and how it's going to affect them individually, and then passing that education on to the people that are making the bills, right? Everything starts with education and understanding, and then it infuriates you too. The more you know about it, the madder you get, and the passion just gets a little bit hotter, right?
Well, and that's a good point. The personal stories make all the difference. When you hear about a person with cystic fibrosis not having access to care and not knowing that there's a product on the market that could be so impactful and that they can't get it, I mean, those kinds of stories we found to be just tremendously impactful in terms of helping policymakers understand the potential impact of their decisions.
That's what we found as well. Personal stories are key, and that helped my daughter get access at 12. We advocated huge, because it was caught in the negotiation process. It had been sitting in there for a year and a half, and it wasn't okay. And we educated, and we got loud, and we did end up getting it passed and got the drug covered. But you have to get really loud, and you have to make people understand, and you have to put a face to the disease. And, as soon as it's personalized, and as soon as there's a story that you can look at, it all of a sudden makes your heart. And I'm not saying you have to make decisions with your heart, but you have to have a heart and make decisions, like there is a place. We're human beings, right? We need to care about each other, and we need to find solutions. And I think that's part of the problem, is nobody's looking for solutions half the time. Half the time, they're just so busy battling with each other and looking over the patient, and not putting the patient in the middle of these and working together to come up with solutions. There's Maddie and I at Queen's Park fighting away. Patients need to be the center of this, and we should have nonpartisan decisions, and all government working with pharma. Right? It sounds like kumbaya, but maybe that's what it should be, so that we can get things done and have people get the drugs they need.
Yeah.
I wanted to put up your address, Sarah, all your contact information, although I did put it also in the chat as well for people.
Oh, thank you.
Sure. I'm going to stop the share so you can look in the chat. We only have a couple minutes left. I know that Jerry had a few thoughts that he put in there. He didn't have any questions, but if you can see those, if anyone has any questions before we wrap up.
Jerry's from Canada, I think, and he's one of our gurus. So where's his information? I want.
Jerry, will you share your information with us, your email? That would be great.
Yeah, Jerry's he's got a lot of that good hardcore stuff. It's so different coming from the patient perspective versus, as a whole different level. There's always so much to learn.
Thank you.
Yeah, Jerry, thank you for these comments. I'm looking at the chat right now, and
Where am I?
you're absolutely right about small rare disease populations and the methods, and it is a particular impact on small disease populations to use the quality adjusted life year. And we often get asked, getting to your last point in the chat, we often are asked, if not QALYs, then what? And I think you're right that there is no perfect cost effectiveness study, no perfect way to look at cost effectiveness. But there is some innovation happening in the field, which I think is really exciting. I would just point to the Innovation and Value Initiative and the PAVE Center over at University of Maryland, and obviously PCORI, the Patient-Centered Outcomes Research Institute. We're really excited that PCORI in particular is taking on looking at alternative methods to the QALY for analyzing cost data in their studies. So there is a lot of innovation happening, but I think you're right. Not necessarily going to be a one-size-fits-all solution that necessarily meets the needs of every population. And so that is something I think we all have to keep in mind.
Absolutely. And it's a continued communication between all of us. Everybody has so many different perspectives. Canada, you know, Beth, you're in Canada, and everybody has so many different ways to look at it. And we just need to be on a level playing field with everybody and communicate.
Absolutely.
Beth, any last thoughts? And then we'll ask Sarah.
No, I just keep repeating that I think that patients need to be considered more in this process. I think they're left out, their opinions, their quality of life, their perception of their quality of life. It's not for anybody else to decide what their quality of life is and how it's improved. It's up to them. And I also think that their specific teams need to be involved more, because nobody knows you better than a team that's been working with you in your health since diagnosis. And I think that they need to be more involved, and they need to be trusted to use drugs effectively and efficiently. Like, it just seems there's such a lack of trust there. Doctors are not going to give you a drug that's not going to work. That's just not how they roll. They want to make you better. And if the drug's not making you better, you're not going to be on it. And I think they need to be more part of the process as well. So I think that's a big piece that's missing out right now. I think we've got too much regulation and less focus on the doctor-patient experience and how they can make things better.
Sarah?
Well, I couldn't agree more with all of that. I think here in this country, we've put such a priority on personalized and precision medicine and innovation and helping patients make the right decision for them, right? We put a lot of, we've given a lot of, it's important. I mean, we see this in a lot of the comments that President Biden has made around, particularly with regard to cancer. But you're not going to get to that personalized precision medicine. We're not going to see the benefits of that if we are basically saying we're not going to get people access, that we're going to use a cost-based analysis to determine what people can and can't get. That's going to be a real challenge. And so I think, we're excited that there is such bipartisanship in the context of opposing QALYs, but we're also very cognizant that private payers here in the United States do use them. They are informing decisions. States are increasingly referencing them. So we still have a long way to go to make sure that we get this metric out of our system.
I agree, we do. And you see it all, Sarah, because you're dealing with everything and you're a wealth of information. So I just wanted to thank Sarah Van Geertroden, who's the Executive Director of the Partnership to Improve Patient Care, or PIPC. She's fantastic, as well as Beth Van Stone, who I also love, the mother of Maddie, and they're in Canada fighting the great fight, CF Get Loud. She is the director of the Cystic Fibrosis Advocacy Team there, and really doing fantastic work in Canada. So much more needs to be done in America. I mean, you've got us, we're behind you. So we're one CF community, so we're all working together. And thanks everybody who joined us and for all your input. And this is recorded, so you can watch it again or send it to someone else if it will help them learn more about ICER. Thank you.
Thank you.
Thank you. This was a pleasure.
It was. Thanks.